later than 2 o'clock this afternoon. Thank you, Callum. As chair, I am duty bound to take you through some housekeeping. We are on MS Teams, so as is traditional, could you please mute when not speaking? We will be having a short plenary session at the end of this event, so that will be chaired by my cabin crew today, Helen and Callum and Kate. We are recording this session, so it will be available after. And we're using some new technology. We've got a QR code you can see on the screen at the moment. So if you want to hover your camera over that QR code, it'll take you to the slide set after the event. Thank you, Callum. So moving into the criteria to reside, I'd like to welcome Dr. Amit Arora and Dr. Andrew Williams. Amit is a practicing geriatrician in the University Hospital of North Midlands and is also a clinical director of ESIST in the East of England. Andrew is a practicing geriatrician in Dorset and our clinical director for ESIST in the Southwest region. Gentlemen, over to you. Thank you.
Thank you, Mark, and thank you everyone for having us today. So straight to the point, some of our traditional approaches that we've used have focused very highly on the highly complex 20% of patients, which have demonstrated great progress. So the various improvement tools that we have used have made visible impact over the last few years. Having said that, over the last 18 months or so, we have done some work around the other hospitals, my own hospital included, and it was recognized that there are some further gains to be made in the remaining 80% of patients. Then the home first modeling work from John Bolton gave us further insights regarding the discharge destinations, and it suggested that the simple discharges, i.e. the pathway 0 discharges, constitute around 50% of those patients over the age of 65, and pathway 1 patients are in the range of about 45%. So that only leaves about 5% of patients who would ideally need a bed-based solution, whether it is in a rehabilitation bed or a nursing home, care home setting. Of course, there will be some variations at different times, but as a whole, this seems to be the case. The new discharge guidance, which came out during the pandemic, states that all patients with an inpatient stay should be assessed against criteria to reside at each daily board round, as well as in the weekly long length of stay reviews. So the question is, what is criteria to reside? So when I asked my own colleagues in my own hospital about 9 months ago, people didn't know much about it, but I think the awareness of this is growing, and we'll talk about this a little bit in more detail. So essentially, the new criteria to reside guidance was developed in conjunction with Academy of Medical Royal Colleges. It has 11 criteria against which patients should be assessed whether or not they should be in an acute hospital, and it can also help identify gaps in the system-wide availability of various services, and we'll hear more about these in a minute from Andrew. As a clinician, personally, I fully recognize that it can be very difficult to base any clinical decisions just on the basis of tools or criteria, because tools do not replace years of clinical experience and skills and knowledge and insights and the sixth sense. But tools do help, and we all use different tools in our daily clinical work. Jyoti, who is the national lead for reducing in-hospital length of stay, has already discussed the discharge policy with the CDs and medical directors in the region. But today is very much towards implementing the criteria to reside for improvement. Many hospitals in other areas have started using criteria to reside, and whereas it is fair to say that probably no hospital has perfected it yet, some may be better than others in implementing this as a quality improvement tool, and this is very much work in progress. And this is all about patients, their outcomes and improvements, although there is a requirement for data submission. I think as a team, we can signpost you to various services that have adopted it well, and not just criteria to reside, but other services as well. We will leave our contact details, and you can request any resources, and we can answer any queries or facilitate any improvement approaches that you might want to adopt. I'll now ask my colleague, Dr. Andrew Williams, to talk you through the process that has been successfully used in some places who have implemented Criteria to Reside as a QA tool. And I'll see you all in the QA session. Thank you. Andrew, over to you.
Thank you. So as Amit said, I'm a anaesthetist clinical director in the South and also a geriatrician down in Dorset. Just really going to talk a little bit, so Amit's done some of this already, but just a little bit more detail about the interaction between the discharge service policy and Criteria to Reside and Discharge to Assess, and how we can try and get away from using the Criteria to Reside as a kind of reporting measure to a tool for quality improvement to better engage clinicians in thinking about flow, and how we can use that as a tool for trying to improve longer length of stay, if that's okay. So can we go on to the next slide, please? So I think that's just really what I'd said. And if we go on to the next slide, please, Callum. So this, I'm sure you've all seen this. This was the hospital discharge service policy and operating model, came out in August for implementation in September. This was the kind of second iteration of it, having first come out in March as the pandemic response. And within that, if you go on to the next slide, please, Callum, we had the Criteria to Reside. So as Amit already said in his introduction, these were a deliberately trying to be as binary as possible set of criteria that had little grey to them, that had been approved by the Academy of the Medical Royal Colleges as being appropriate reasons why someone should be in hospital, and if people didn't meet them, appropriate reasons why people probably should, in an ideal health system, be able to receive their care in an out-of-hospital setting. Can we go on to the next slide, please, Callum? So this is just them in a little bit more, a bit of a more readable format, put on the slide rather than the direct out of the policy. So some of these are really straightforward. No one's going to say if someone's on intensive care or high dependency, they should be being discharged. There are then three around kind of therapeutic options, some around some functional bits, some relating to time after interventions and surgery. So if we go, can we go on to the next slide, please, Callum? These fit quite nicely into these four groupings that I think, in terms of thinking about how they work and also kind of trying to take them out onto the wards as a kind of, how do you make Criteria to Reside work, and how do you get your clinical teams thinking about Criteria to Reside and applying them to individual patients. That this, I think, is a really nice set way of looking at it. So is their physiological upset sufficiently great, and that's using their news score and looking at a news score of more than 3. Are there therapeutic interventions that require them to be in hospital? So being on oxygen, non-invasive ventilation, having intravenous fluids or intravenous medication more than twice a day. And that was put in because there are lots of places, lots of models, particularly people who need long-term IV antibiotics, where those can be delivered in the community. There were then 3 recovery parts about surgical interventions and procedures that are clearly kind of quite straightforward. And then the functional ones, which are kind of hardest, I think, to look at and be really binary about. So at the last hours of life, I think, is one we'd all recognise people in. The diminished level of consciousness, again, is kind of quite straightforward, and the acute impairment in excess of what the home or community care provision can provide at the moment. And I think that's the key to this. A lot of these are not saying these people must leave hospital, and there was quite a lot of stuff in medical press about things and people being quite upset about them and taking away professionalism. To me, these are a set of guidelines. Like any other guideline, as a clinician, I should be able to deviate from them for an individual patient of mine. So I should be able to say, yes, my patient, Mrs. Smith, does not meet these criteria, but I can justify why she still needs to be in hospital, and that should be able to be challenged and stand up to challenge. So these are not a binary, some people said in the medical press, some kind of dark force is going to come and remove these patients against your wishes as a clinician. These are a set of standards that are deliberately trying to be binary in their nature. So you either got a new score more than 3 or less than 3, getting away from that old medically fit for discharge kind of criteria we all had, where my medically fit for discharge was different to yours, and it was quite hard to standardize that and look at it. Can we go on to the next slide, please, Callum? So there are also a set of criteria for community hospitals, and I think, to be fair, these were added a little bit of an afterthought for community beds, and it's much harder, I think, to be really dogmatic and precise about what exactly is the function of a community hospital. So these are a little bit more nebulous and open to interpretation, but if you read the statements that come after them, I think it helps kind of understand what they're about a bit more. So there's a couple that are clearly kind of obvious and straightforward about no plan and waiting for information from an acute trust. I think that kind of came out about, people awaiting a fracture clinic review who are non-weight bearing, you can't progress them. Again, end of life, it was quite straightforward. Medically unwell, there are a group of people in community hospitals are kind of quite sick. That varies a lot from one community hospital to another and how they're set up. And that those two, between the highly dependent and increased dependency, I think are trying to get around what could be delivered in the community and what really requires a bed-based service to provide it. Can we go on to the next slide, please? The whole point around criteria to reside is we've moved away from this idea that people stayed in hospital until they were medically fit and then therapy fit and had an MDT plan to say, in the discharge guidance, as soon as people no longer meet the medical criteria for needing to be in hospital, services should be set up along these pathways, and I'm sure it's all very familiar, I'm sure you're familiar with it, to be able to leave the acute hospital as soon as they no longer need to be in an acute bed from a health perspective. They may need ongoing rehabilitation, discharge planning support, but that should be able to be delivered in a non-acute hospital setting where it safely can be done. And these are the pathways: pathway 0, going home with no care; pathway 1, a package care; pathway 2, to a short-term rehabilitation, beds off in a community hospital; and pathway 3, looking at long-term care, that I'm sure you're all quite familiar with. Can we go on to the next slide, please? So why have we got criteria to reside? I think they're an attempt to almost standardize that medically fit for discharge concept, medically ready for discharge. We gave it different names in different places, but as I said, there wasn't clarity about what that was, and it did vary very much from person to person, and often, certainly in my practice, end up with kind of quite difficult conversations about, I'd say I felt someone's medically fit for discharge, and the social worker would come back and say, oh, but you've not addressed X, Y, and Z. So often created quite a lot of conflict. And to me, the beauty of criteria to reside are two purposes: about looking for unwarranted variation. And I think that's looking at a high level between systems. So what unwarranted variation is there between hospital A and hospital B? And that's often around what community services are there to provide support in some quite long-standing historical commissioning decisions. So if you haven't got a good community service, you're going to have more people stay in hospital than if you did. And to me, criteria to reside are a way into trying to be able to address that and have some of those conversations about what's there. And then secondly, I think that unwarranted variation within a trust, that's often around clinicians' behaviours and understanding of risk and how they respond to that. So I would imagine in each of your hospitals, if you talk to the bed management team, they can predict the Monday morning bed state pretty accurately based upon which clinicians are on call over the weekend, and that's not really reasonable. I think we've struggled to have those conversations, and in a supportive way. I'm not saying it's wrong to be someone who's more risk adverse, but it's how do we start having some understanding of that, some data to start kind of knowing where people are, and then start having some supportive conversations. Say, look, what can we do to help and support you, because we know that your length of stay is often longer than your colleagues, or this ward rather than the other ward. And I think if we want to take things through to a kind of natural conclusion, if criteria to reside are reasons to be in an acute hospital, then actually shouldn't we use them at the front door, and shouldn't they be criteria to admit as well? So if someone doesn't meet the criteria to reside, shouldn't we be challenging back at the front door, saying, does this person really need hospital? Could they not be managed in a different way in the community? Could they not be going to an STEC type clinic or something else as an alternative to admission? And again, there are guidelines, so there will be individual patients that don't meet the criteria that very clearly need to be in hospital. So you could have an acute MI and not trigger any of those 11 criteria. You clearly need to be in hospital. No one's going to argue with that and say, no, can you have your PCI done in at home? We'll send someone out to do PCI in the community. So they're a guideline, and I think that's a way to introduce them to clinicians, as about, these are a guideline. You should be able to justify why if you want to deviate from them, but if there's a good justification, we should be able to accept that. And to me, the way I address them with clinicians about trying to get people understanding the uses, you may not have those services there now, but what services would you think there needs to be in the community to feel safe to discharge this patient who doesn't meet the criteria to reside? So turning it on its head, using it as a conversational way into how do we look at this from a quality improvement perspective. Can we go on to the next slide?
5 minutes, Andrew.
So I think, to me, that's a way of trying to get, how do we get clinicians engaged with flow, How do we get them to understand that each time they say, oh, we're not quite sure, we'll just keep Mrs. Smith in a day longer, that adds up to a long length of stay, some real deconditioning and some real harm, as well as the impact that has upon others that can't access those services at the front door and are kept waiting on trolleys. How do we think differently about length of stay and stop that conversation where the default is always, if in doubt, keep them a bit longer? But that to have those conversations about risk, we need to get people thinking differently. We need to support them in that. What can we do about safety netting, about virtual wards on discharge, other ways of making it easier to discharge people? And when we look at trying to discharge people kind of differently, the system doesn't like it, but we make it really simple to admit someone. So if you're in ED, the ED doctor bleeps somebody, one phone call and admission's organised. You try and do something different to make that not happen. You spend hours on the phone. So we need to think about how do we make our systems better that support going home as being the default option, not coming into hospital. And challenging back to clinical colleagues, as a geriatrician, all the evidence I've seen about reducing length of stay is it reduces harm, it reduces falls, it reduces hospital-acquired infections, reduces pressure damage, reduces complaints, and readmissions don't come from early discharge. They come from the deconditioning in hospital and decompensation and people being out of their normal routine. So actually, when you reduce length of stay, readmissions don't go up. Can we go on to the next slide, please, Callum? So in the Southwest, we started doing some work trying to look at reviewing these occupied beds and trying to say, how can we look at this at a system level about how can we understand what those blocks are? And it's often not an individual organisation that can fix this, about how can we look across the acute and community and local authority provision about how can we unblock these things? How can we get better clinician engagement? And how can we start having conversations about what can we do differently to only have people that need to be in acute hospital in an acute hospital and not keep people there in a well-intentioned way, but associated with some real harm? Can we go on to the next slide, please, Callum? This is just a really quick bit from an anaesthetist colleague in the Midlands about their journey about implementing criteria to reside. It's a really busy slide. Just if you look at the bar charts, green is people who meet the criteria to reside. Orange, they didn't have a criteria recorded, and red, they didn't. And this journey started in November and ends in mid-February. So over 2.5 months, did an awful lot of work trying to get clinicians using criteria to reside properly. Clearly, the orange, the no data recorded goes down significantly, but actually, the more you use this, you will find the numbers of people that don't meet the criteria to reside goes up as a consequence. The better you get at recording it, the more people you'll find that don't meet the criteria to reside. Go on to the next slide, please. This is the same time period, their data for their emergency admission. So some variation, but no real change in their emergency admission numbers. And if we go just onto the next slide, Callum, over that time, so yes, this was associated with some of the COVID changes, but actually, if you look at the peak that they've got in their 7-day length of stay, some of that was related to COVID, but the improvement they had at the end, and if you go on to the next slide, if I just show you 7, 14, and the next slide is 21, their view was when they started getting clinicians recording criteria to reside, it did impact upon length of stay at all different lengths of stay. And if you go on to the last slide, this is their total numbers of occupied bed days. So their view was when they started looking at criteria to reside, they had a significant improvement in their occupied bed days. That's probably more than 10% of their bed base is quite a small DGH. Just on to the last slide. So I would say in conclusion, beds are your biggest expense. Now we've got something that allows us to measure who are in our beds and why are they there. And previously, I don't think we really knew that. So how can we start thinking about moving away from the who's the most stuck patient, and the old DTPL list kind of got us thinking about the really stuck patient, and we all wanted to discharge that really difficult patient. But how can we start looking at the people that across the whole spectrum, about people that are in our beds and don't need to be in our beds, and start using that kind of Pareto principle and focusing on those quick wins and those kind of easier areas rather than those really stuck patients that stay in our hospital beds for a long time. And just lastly, as a kind of parting thought, the discharge requirements were funded kind of centrally with an extra pot of 588 million in September, reaches the end now at the end of this month, and actually we haven't managed to spend all that. So even with new money to try and do things, the system still wants to keep people in hospital. We had a chance to do things differently as a whole system across the whole country, yet we kind of somehow struggled to make that change happen even when there was new funding to do it. So I don't know what the way in is. It's a difficult thing to change how we work, but to me the criteria to reside are a good way to start that conversation. that's me finished. Can I hand over?
That's great. Thank you, Andrew, and Amit. Thank you for that. Just before we move on to the next session, my cabin crew advised me that I forgot to mention that if you do have any questions, please put them in the chat room, and we will be having a plenary session at the end of this session. So if you could put any questions in the chat room. I think the emerging theme coming out of today is that there is a need for a systematic review of all patients in our hospitals to ensure that only those who require in-hospital care remain in hospital. So another lens we're looking through is with our next speakers, and I'm delighted to welcome Ned Hobbs, who is Chief Operating Officer from Walsall Healthcare, Dr. Esther Waterhouse, who is the Deputy Divisional Director in Medicine at Walsall, and Dr. Simon Harlin, who is the Clinical Director in the community. Very welcome all, and over to you. Thank you.
Thank you, Mark, and thank you very much for having us. I'm going to kick off with a little bit of intro and context about Walsall and the journey we've been on from an emergency care and patient flow perspective. And I'll then hand over to Esther with Simon's contributions to talk through the news or low news score peer review process that we've recently given a go. Hopefully we've got some learning that may be useful and we'll be sticking around. So any questions in the Q&A section we'll be happy to take. If I could have the next slide, please, Callum. So I'm going to just cover a little bit about the sort of organisation we are, and then from our patient flow improvement journey, a little bit about what we've done in ED, what we've done with same-day emergency care, and what we've done with inpatient and particularly complex discharges back into community setting. And that's for a reason, because I think that leads, particularly as Amit and Andrew have said, based on the Pareto principle, to this big chunk of inpatients in the middle that we need to do everything possible to make sure they're in the right place with. So next slide, please, Callum. So anyone in the east of England that's less familiar with the West Midlands, Walsall's part of the Black Country. We're just north of Birmingham. As a trust, we're an integrated community and hospital trust. We're also very importantly host provider for our Walsall Together partnership, and that includes ourselves, commissioners, primary care, mental health, council, voluntary sector and housing. Really important and a big part of what we're able to do with our community pathways in particular. We've got about 500 G&A beds. Pre-COVID, we used to see about 260, 270 type 1 attendances. That's around 200 a day currently, and we've got a co-located UTC on site. And next slide, please, Karen. And again, please. So the context for Walsall is up until 2 years ago, we were an organisation in special measures, and special measures was as a result of quality problems in both emergency care and maternity some years before that. So emergency care has been a historical issue at the organisation, and the need for improvement has been really clear for us. Within the ED itself, and you'll see on a number of our charts, we've been traditionally struggling to triage patients in a timely fashion within 15 minutes of arrival. That actually last year deteriorated on introduction of our electronic patient record, but following the bedding in process of our EPR in ED, we're now delivering the best triage times that we ever have done, and are on course this week for more than 90% of patients to have been triaged within 15 minutes. Next, please. Ambulance handover has actually traditionally been strong at Walsall, third best in the Midlands, and even despite the adjustment period post Medway, we've held up well during waves 2 and 3, over 98% of patients handed over within 30 minutes. Next, please, Callum. From a wait to be seen perspective, this has always been a problem from Walsall historically. We've not seen a high enough proportion of patients within ED within an hour, and you'll see that results in non-admitted pathway problems for us. However, again, post-Medway introduction, the journey we've been on since then, we're delivering the best performance that we ever have done for timely doctor or practitioner assessment. And that, of course, gives a better chance for those that do need to be referred for admission of getting them in good time. Next, please. So our Achilles heel historically has been non-admitted pathways, which is unusual. Of the patients that spend more than 4 hours in ED, 3/4 of ours are either non-admitted or late referrals within the emergency department. So we have quite an internal local issue for improvement within ED. And this suffered further during the adjustment period post-EPR and is beginning to get back to where we were before, but has got a long, long way to go in my view. Next, please, Callum. And consequently, despite having delivered the best 4-hour emergency access standard that we ever had done on record last summer, we then took the hit post Medway. Been a general improvement, a steady general improvement, with the exception of the first couple of weeks of January with the peak of wave 3. But we have a long way to go, and on the whole of this, I would say we are far from perfect in an emergency care perspective. But we do think we've done some things which have demonstrably delivered improvements. Next, please, Callum. I mentioned we don't have, we're unusual in that most trusts' emergency flow problems are exit block related. That's a smaller proportion for us, and as a consequence, we very, very rarely have 12-hour trolley breaches. For any coups that might be on the call, we measure DTA from the point of referral. Not from the point that inpatient specialty sees the patient. So I'm confident that we are robust in that sense. Next, please, Callum. So big emphasis for us in the last year or two has been on same-day emergency care. And as Amit and Andrew said, this has been obviously a huge emphasis nationally. And it's one where we're very proud of what we've achieved. Next slide, please, Callum. And it's not just about medicine, or it hasn't just been about medicine for us. So we've gone from a position where about 30% of our acute surgical take was being managed without overnight stay, to a position where consistently over 50% of the acute surgical take is being managed without overnight stay. And indeed, we've even had individual weeks where that's been over 60%. And a new surgical ambulatory care unit's been vital. That we introduced last year in delivering that improvement. Next, please, Karen. In medicine, there's a bit of a more volatile chart because we temporarily, in wave 1, stopped having pretty much any ambulatory medical patients turn up. But ignoring that weird bit in the middle in wave 1, there's been a similar underlying improvement, both through our acute medicine-led ambulatory emergency care unit and our elderly care-led frailty service, which is now integrated with our community teams. So we're fairly confident that patients that can be managed without overnight stay are generally being managed without overnight stay. Of course, there are exceptions to that. So then if we move on to the inpatient setting, please, Karen, and the complex discharge part of it. So Simon and his wider community division team have done fantastic work in recent years, and if this axis went back further, our number of medically stable for discharge patients in hospital was even higher further back, but has broadly halved over the last year, and importantly been sustained with the pathway adjustments that we've made since COVID, particularly with DST assessment processes, but also other ways of safely discharging people out of the acute setting. Next, please. That's resulted in a reduction in the number of patients that we've got over 7 days in the hospital. And next, please, Callum. And more starkly, and particularly importantly, because this is probably the group where the deconditioning is worst, the number that are over 21 days in hospital, which has been sustained at a much lower level. And this is the proportion. So even if total admissions have gone down, which they have done at periods during the last year, this is actually the proportion which has remained low. Next, please. Combination of more ambulatory care, fewer long stay patients. We've pretty much eliminated medical patients in surgical or gynae wards, and indeed even during peak pressure in wave 3 have had no no outliers of note. Really important, I think, from a quality perspective, and something that we hold strong in our site safety meetings. Next, please. And we've also worked very hard on the configuration of our discharge lounge and the processes for accessing discharge lounge, which has meant that our proportion of patients leaving a ward before midday has gone up considerably. This still has much more to do. We're far from perfect here, but the progress has been incremental and good in the last 18 months or so. Next, please. So there's lots that we're proud of on an emergency care perspective, but there's also equally an awful lot we need to do, and I won't recap on that. What I think struck us is that having put a lot of effort into same-day emergency care and a lot of effort and good improvements into reducing the longest stay complex discharges that no longer required acute hospital care, actually the biggest bulk of patients is that group of inpatients in the middle. And that led to us questioning, exactly as Amit and Andrew have described, is there a reason for those patients to continue to reside in an acute hospital setting? How do we know that there is? How do we systematically assess that? And it was those sorts of questions, particularly around Christmas and New Year and then early January, that led to our low news score peer review process. And Esther's going to talk you through that in just a second. Worth saying, the first structured peer review process we did was only 6 or 8 weeks ago, so it's very, very new for us. We're learning as we go along, and indeed we'll continue to learn and refine the process. But I hope it gives another lens to consider that question about whether patients continue to need to reside in hospital. So I'll hand over to Esther at this point.
Thank you very much. Can I have the next slide, please? And the next one, please. So I'm a consultant in palliative medicine based at Walsall Manor, and I've been Deputy Divisional Director of the Division of Medicine and Long-Term Conditions for about 8 months now. And it seemed a sensible thing to have a look at the patients with a low news score to see if we could get them out in a safe way and challenge our colleagues, really. So what we set up it's really been quite informal so far, and we're looking now at how we take it forward. I did this work with Sister Kirsty Donaldson, who's a Band 8 community nurse who works in the Integrated Assessment Hub at Walsall Manor Hospital. So if you like, a sort of an in-reach job, very well aware of what services are available in our community teams, and very aware of the need to get people, the benefits of getting people home as opposed to the potential harms of keeping them in hospital. So what we did was we were able to pull a list on each ward, by ward, of patients who on their last News 2 OBS chart were scoring 0 to 1. We selected 0 to 1 really initially just to really focus on that stable group, and to be honest, to be able to deal with the numbers. And we excluded those initially who had already been deemed medically fit for discharge or medically stable, because there was already a process in hand for those people, and there were already pathways looking at how they can go home. So we were trying to see whether we could find a new group of people or a new challenge to offer to our colleagues. So if I could have the next slide, please. So it doesn't sound much, visit all medical wards, but even in a hospital this size, there are quite a few, and we went round together. And when we got onto the ward, we pulled up a list of the relevant patients, and then had what we hoped was a constructive discussion with the nurse in charge or the doctor, and ideally both. It's much better done multidisciplinary, and we were a nurse and doctor, and it made sense to have a nurse and doctor too. I have to say that the ward teams on the whole took this extremely well, and despite being really busy at the time, were willing to sort of stop what they were doing and come and go through. What we were able to do really was to challenge, to listen when they said actually they may score News 0 to 1, but there's very good reasons for them still being here, but also to look at education around alternative options for providing care. And we were able to explode a few myths. So we had a few myths of, well, they can't go out on IV antibiotics. Well, they can. We've got a very good community intervention team who can do that. Or they can't go out on those antibiotics. Well, actually they can, because a team can do more than twice a day, for example. So some people had some really strongly held beliefs about what was possible and not possible in the community, and it was great to be able to sort of diffuse those. There's one patient we got to a hospice that just needed a clinician to clinician discussion, which I was able to do. But mainly it was getting people home. And of course we were able to see the patient or talk to the family if needed. What we also did was we provided, once we'd done this a couple of times and we sort of saw what the questions were, we provided a sort of crib sheet on an A4 laminated paper that's on all the drug trolleys, on all the notes trolleys now, so it should be visible to the clinicians when they go around, just reminding them of the services that are available in the broader trust. Next slide, please. What was our learning? Well, the learning was just as the previous speaker said, really, this does not exclude unwell patients, and particularly those with liver disease didn't seem particularly to trigger on news scores, but might have been encephalopathic or unstable and needed to be in hospital. So that was a particular group that we identified. We also identified the time of the visit mattered. So if we go too early, the teams haven't really got to grips with what the day looks like and who the patients are. And if we go too late, it's too late to influence things that day. So we sort of felt late morning, sort of after the ward round was helpful. But then again, you're not getting your admissions particularly early in the day. So that issue we haven't fully resolved yet. Who does the review seems to matter. Sadly, when the nurse went to a couple of wards on her own, she felt she didn't get as good a reception as when she went with a doctor, and I think that needs to be challenged, and people need to be able to talk to each other and support each other to get the right care for the patient. And really, I suppose the learning for all of us was that, just as everybody else has said today, the score is a prompt for a discussion and for a challenge rather than for a particular action. And I think if you take it as that, you're much more likely to get engagement and discussion and buy-in than if you go around going, these people have to go home, because there's obviously lots of reasons why that might not be the right thing. The other thing I found is that we've done it 3 or 4 times now. The first time we identified a whole load of patients. Interestingly, further iterations we've identified less. I can't quantify that, I'm afraid, and it's been difficult to quantify patient by patient what we're achieving, because you might not get them out today, you might get them out tomorrow, and how do you count that? And I suppose what we're trying to do is use an individual patient focus to change a whole system, which is sort of the other way around to what people often do. So it's been an interesting process to go on. We will continue, but I don't know at what intervals, and it won't always be me. I think we need to bring other people in to do those challenges. And I think that's the end of my slides. Oh no, that's it. Future, thank you. So really importantly, and I've alluded to some of this, how do you change culture about the risks and benefits of being in hospital? How has COVID changed people's perception of risks and benefits of being in hospital? How to increase hospital staff's confidence. So we did have some people who said, well, you may be able to do that in the community, but I'm not sure you'll do it very well. So, it's very easy to be confident when they're in a bed under your care in a ward. How do you improve confidence when they're going out to their home under other people? Winning over skeptics, I've talked about a bit, and then I've already mentioned really the challenges at an individual level of measuring impact. And we will have to start looking at some of the system-wide measurements that Ned's already described to see if we're having an impact. There are other things happening as well. I think the other thing for the future is how you integrate all of this with constant with all the other changes that we're asking people to make, and some of the other initiatives we have to support people to get home, like reviewing the very long stay patients and so on. So it's just making sure that we're not duplicating work or pressure on the system, that we're working collaboratively together to improve things. And I think that is the last one. Yes, it is. Thank you very much.
Thank you, Esther, and thank you, Ned. Some very, very compelling presentations there. I'll just hand over to my colleague Helen and Kate now for the chat room.
Lovely, thanks, Mark, and thank you to all the speakers today. I think there's quite a lot of discussion in the chat room actually. So what I'll do is I'll just put a couple of questions now. But if anybody does want to pose your own question, then please pop your hand up, and then we can come straight over to you. Firstly, there was a comment really around really valuing the use of using Criteria to Reside as a quality improvement tool. And that has been replicated actually as we've gone through into your presentation also, Esther and Ned and colleagues. One of the questions around that, or sort of comment really, is about what's required in the community to build the confidence to discharge. And I think you touched a bit on that, Esther, with regards to what perhaps the perception of what can be managed in the community and what can't. So your myth busting around that, I think, has really made, there's a lot of people agreeing with that. I don't know if you've got any other comment to that bit.
Perhaps I can come in, Esther, if that's right.
Yeah, can I just say one thing? I think because we're all one trust here, that enables us to be really confident. I mean, sure, we can be confident about other organisations as well, of course we can, but I think sometimes when we remind people that we're all in the same organisation, we all work together anyway, that can be really, really helpful. And I know that doesn't apply to everybody, so I suppose it's how you engender that feeling that you're all working together anyway, with all the cross-boundary issues. But I'll let Simon pick this up as well.
Yeah, so I think that's a really interesting point. So it is about winning hearts and minds, actually. So proof's in the pudding. So we demonstrate that we do things well. So there's a perception that Esther just described that people don't think we do things very well in community services, but the evidence that we've got is quite the converse. So I'll give you an example. So we've got a rapid response team that take referrals for patients who are thought so unwell that they probably would otherwise be in hospital, but we manage them at home, and we keep 92% of those patients out of hospital. And then once we've discharged them, we have a readmission rate into hospital of about 2%. And thinking about some of the readmission rates for people over the age of 75 from hospital, roughly around 20%. So actually we do things pretty spectacularly. But what we have focused in is on the capacity of our community teams and making sure that we were able to preserve that as much as we can, and particularly around things like hospital avoidance schemes, and thinking about the skills of our staff as well. So we've very much focused in on what skills do we want our staff to be able to have and making sure that they've got them. And the other important thing is the engaging with clinicians, as Esther's described. So having visibility, but making it easier actually to refer into community services than it is to pick up the phone and make a referral to the medical registrar. So that's what we focused in on as well. So we've got a care navigation centre, which is our single point of access into community services, into which people can make referrals as easily as we can make it. And I think that's been important too.
Thank you, Simon. Another couple of comments just on this bit with regards to the increased use of technology in the community setting is playing a part in increasing that confidence also, and a couple of comments around virtual wards and positively forcing people to think differently about where care can be accessed and what the acute care is like. Just another question that's with regards to your presentation from you guys over in Walsall is around, was there any challenge from any ward AHPs? Just a question.
Interestingly not, no. No. And perhaps we should have engaged more with the AHPs. You know, it tended to be with the nurse and the doctor. So I think that's a very valid challenge for us as we continue developing this. But no, very little challenge really in terms of why you're here, what you're doing. sometimes it was, no, that patient isn't suitable to go home, and good reasons, but you know, that's not a challenge, that's just a point of fact or view. So yeah, didn't get that. Simon wants to comment.
Oh yeah, perfect.
I just wanted to make a comment about virtual wards. So yes, we do have a virtual ward, and it is a new thing with COVID. And we initially set up the service to look after 10 patients who were discharged from the hospital at any one time. That's what we thought the capacity was in the service. But at one stage, I think, Ned, we had about 84 patients. And yes, it was a very slow uptake from the hospital to refer patients out. But again, it was winning hearts and minds. So by the end of it all, I know we've passed the peak now, but by the end of it all, the consultants were falling over themselves to refer into the service.
Yeah, the COVID safe at home pathway has been a huge success from Simon's team, and in conjunction with acute medicine in particular. I just wanted to make a point on the previous question about AHPs. My personal view, having worked in other trusts, is that at Walsall, our allied health professionals, and particularly our therapists, probably don't have a sort of strong stature and standing within the organisation as I think that they deserve and should do. They've got absolutely invaluable skill set. So some of that lack of challenge may be because of that. On the other hand, our therapy services, both in the hospital and in the community, are all under the community division. So they are intrinsically geared towards the transfer of care for patients from a hospital setting into a community setting. And hopefully that means they're more bought into that than perhaps may be the case in some acute hospitals.
Thanks. Do you have any more questions, Helen?
I just wanted to make a point, actually, possibly about skills in community services as well, actually, and I think Ned has possibly prompted me and egged me on in this regard. So we actually look after people in community services that have news scores of 6 and below. So if you think we can barely manage people with news scores of 2 and below, then you've got something else to think about, actually. And in fact, if we've got patients with news scores of 7 and above, they won't be conveyed to hospital if they've got an advanced care plan or ceiling of care plan that says, I don't want to go to hospital. So that's a challenge back to you guys, possibly from a community perspective.
Thank you. I don't know whether, Esther, you've got your hand up, whether you wanted to come back in there at all, or shall I move on to, are you happy for me to move on to the next question?
No, I think I was going to talk about the next question, but I think it's really important for us all to remember that hospitals are not safe places to be, and this sort of idea that if anyone's a bit ill, they go into hospital. You know, I think that was going anyway, but COVID has really shown us how dangerous a place it can be. And I absolutely agree with Simon that we need to have community services that can support and manage these patients, and we're very fortunate to have that here.
Thank you. Okay, I'm just going to take us back to some questions that were asked earlier on, and this is probably more suited to Amit or Andrew. This is with regards to, well, there's a few questions in one here, so I'm just going to start. So the national policy suggesting twice daily ward round reviews. In your opinion, do you think this is feasible?
Shall I say something there? So that's the national policy. I would rather people did once a day and did it well than did twice a day and did it badly. And I'd much rather trying to get once a day happening 6 or 7 days a week than twice a day happening 5 days a week.
Thank you, Andrew. And just moving on from that, this is it's a good question, but maybe quite challenging. And I suppose this is, we've talked a bit about hearts and minds and culture whilst we've been talking this afternoon. And the question is, how do you challenge the really experienced clinicians around a patient when they certainly do things in their own way and in one way, i.e. keeping them in for an extra day just in case? How do you go about challenging those? Esther, you've got your hand up now, I can just see.
I think that's possibly a good question. The thing I think about is about evidence, and the thing that always really strikes me is how the evidence has changed around surgical practice. So when, I can't see how old people are, but when I was at medical school 30 years ago, after bowel surgery, you were in bed, you were drinking sips of water, 30 mils, 60 mils, 90 mils, and that was how you did it, and you would not have dared challenge the professor, but actually that was killing people. And we know that it's safer to feed them quickly and get them up and out quickly. So I think it's, you know, for the people who really say, well, we've always done it this way, that isn't really a good enough answer, and we need to start talking about what evidence we have, and that is, I understand, growing, that getting people out quickly is safer and kinder and a more efficient use of resources and so on. But, you know, other parts of the medical world have changed practice regarding this kind of thing, and the rest of us need to catch up, I think.
It's always good perhaps to ask the patient as well. So you very rarely meet patients who either want to be conveyed to hospital in the first place, but once they're there, want to stay there. So it's probably worthwhile asking the consultant to go and ask their patients, do they want to stay in hospital? And then just try and facilitate that conversation about shared decision making and risk sharing, and actually then proving to the consultant that once they're out of hospital, we do it pretty well, actually.
Thank you. There's just a comment here that's really helpful, I think, around the language that's used around either medically fit for discharge. Alison's commenting that they've changed some of the terminology to medically stable to try and aid some of the conversations and aid those conversations and buy-in from clinicians, which is working well for them. I don't know whether somebody has got their hand up now. I can't. If anybody wants to come in with a question, you are very welcome to ask the panel.
Sorry, my name is Junaid Qazi. I'm from Eastern North Hearts. I'm not sure. Can you hear me? Yeah. My question is for Dr. Harlan, Simon. As part of the this process of setting up these extended services in the community, did you face any challenges particularly with the general practitioner colleagues to bring them on board? Were there any barriers or any difficulties to overcome?
Not in the slightest. So they've bitten our hands off, actually. So we're looking after for them. They're really complex, difficult patients that they don't have the skills and capacity to manage by themselves, actually. So no, overwhelmingly, we've had encouragement and support from our primary care colleagues. And of course, they're significant members of CCGs who've commissioned services like this. So they've been heavily involved in the design and operational rollout of services like this. So no, not in the slightest.
Okay, thank you.
Okay, thank you. If anybody else wants to actually ask a direct question, please do put your hand up. I'm happy I think we've probably got time for one or two more. If I just go to one, this again for colleagues in Walsall, people have found your discussion really helpful and everyone's discussion today really insightful. Just one of the colleagues, Lisa, is just saying it'd be useful to hear how easy you yourselves have found it to get clinical teams on board with criteria to reside, and if you've how that's going for you.
I'm happy to come in on that. So I think as Amit and Andrew said, the key really here is to go back to the principles of is the benefit of someone remaining in hospital outweighing any risk of them being discharged. We haven't used the national criteria data collection structure to base the peer review questions upon. We have our established long stay review process weekly, which is multidisciplinary. We have a specific review process of those that have already been deemed medically stable for discharge. And then we've supplemented that, as Esther's described more recently, with those with a low new score. I think the low new score is the same way in to be having the same conversation as the specific criteria to reside categorization would be. And I think for me, the important point is a peer-to-peer conversation about what's in that patient's best interest, rather than necessarily how you get to be having that discussion.
Lovely, thanks Ned. Okay, I think we're just going to come to the end now, so I'm just going to hand back to Mark. Thank you very much.
Thanks, Helen. And just the final slide, Callum. We hope that you found the session today both informative and giving you some practical sort of solutions to doing this. Just to say that we do have a lot of social media. If you wanted to look at some of our work so far, please visit our Futures site, and we've also got an increasing number of social media platforms. So just in conclusion, having reflected on the presentations today, it occurs to me that the COVID response has allowed us to make some major transformations and probably accelerate some of the work that we wanted to do as part of the long-term plan. But above remote case management and video consultation, which have been quite remarkable, I think the biggest transformation we'll need to make is to actually move to and make a paradigm shift to hospital being an unsafe place, as Esther alluded to, and being an unsafe place, and only patients who require hospital care should be in those beds. So in conclusion, could I thank all our speakers today for their presentations. They've both been compelling and incredibly helpful. I'd like to thank the support team for helping me chair this session. And finally, just to thank you all for giving up your time to spend with us today and to learn about criteria to reside and the work at Walsall. From me, on behalf of the team, we wish you a very good and safe weekend and look forward to seeing you again soon. Thank you very much.